Now, the topic I've got to talk about is diagnostics during the pandemic and how do we do sleep diagnostics. And it's a challenging area. I'm not going to have all the answers for you, but I think I can talk through some of my thinking in this area and give you an idea of what's happened in Australia and what we're doing in Australia. That might help you understand what might work in an Indian setting. So just as way of background, because I'm going to talk using these terms, I wanted to just make sure you understood the different types of sleep studies and what they encompass. So level 1 is laboratory-based polysomnography. Level 2 is still full polysomnography, which is generally unattended in the home, but can be attended in the home. It often is in an Indian setting. Level 3 is a limited channel sleep study that's got cardiac channels and respiratory channels, and has to include at least 2 of respiratory effort and airflow, so 2 signals of those. And level 4 is more than 1 channel and very much a respiratory type of study. And I'll talk also about the group of other that was really introduced in 2017 by the American Academy of Sleep Medicine, which is peripheral arterial. Now, some of the considerations during the pandemic when thinking about sleep diagnostics, both for the patients and for your staff. Now, when thinking about patients, obviously infection risk is very important. We have to think about not just the risk of the test, but the environment we're trying to bring someone into to do the test. So, for example, if in our inpatient setting, there's a high prevalence of COVID infections or lots of staff and patients with COVID infections, it may not be an environment we want to bring patients into. We have to think about the equipment. So what type of sterilisation or cleaning are we going to do between patients with equipment? Some of our equipment that we generally reuse may not be suitable for reusing in a pandemic, and we may actually have increased consumable cost of having to turn over equipment. And there's risk to patients from staff. So staff are working with lots of other patients and in an environment where there's a lot of COVID infection, then maybe the staff may transmit that to patients. Despite these challenges, we need to provide access to care for patients. So they still need access to diagnostic tests for sleep apnea, because this pandemic is something that's ongoing. It's not something we can just sit out for a couple of weeks and wait for it to pass. And they also need access to treatment. And to be able to access treatment, generally you want a diagnosis first to know what you're dealing with. We also have to think about our staff. We have responsibilities and obligations to protect the health of our staff. So thinking about infection risk for them. So are we bringing them into an environment where they may become infected by having patients tested and then equipment coming back to staff? Might that be a fomite that's able to transmit the coronavirus? We know the surfaces. So what do we need to do to protect staff? The other thing we need to think about is, are staff actually available during the lockdown? So have they been taken back to station? Are they just disappeared? You know, the staff that we would normally employ, are they actually available, or are we running on much reduced staffing? So looking at Australia and India, Australia are at a different place with regards to the coronavirus pandemic compared to India. These are our case per day curves as of yesterday. Really in Australia, we've had stable but very low numbers since May. So we're really planning about how do we provide care post the peak of the pandemic when there's still coronavirus in the community, but the actual levels are reasonably low. Now that's very different to the situation you face at the moment in India, where you're still having increasing numbers of cases in the community and still very much in the thrust of a high number of acute cases in the healthcare setting. And that obviously has implications for the type of diagnostic testing and diagnostic considerations, as I'll talk about. Because if you look at our response in Australia, our professional body, the Australasian Sleep Association, put out these different guidances at these different dates that fitted very much with the peak in incidence of transmission in Australia. So March 26th, there was a guidance to essentially stop all non-essential sleep diagnostics, be they attended hospital-based level 1 studies, or be they level 2 studies that were face-to-face. As I'll show you, that created a bit of a hiatus of testing whilst people got organised with alternative ways of delivering level 2 studies. But then as we came past the peak of the pandemic or the peak of cases in Australia, and from the start of early May when we had low levels of community transmission, there was a recommendation to be able to cautiously recommence diagnostic testing and vigilance testing, and also to cautiously recommence home-based testing with face-to-face setups, but a mandate from the federal government that that would only be at 25% of our usual capacity and that all patients had to be pre-screened. In Australia, we had low community transmission through May. So then by the end of May, we were then allowed to recommence PAP studies. In my own hospital, we've only just recommenced those this week because we just have a higher incidence of cases in my state, in Victoria, than in other states in Australia. So we've been a little more cautious in recommencing those. To give you a flavour of what's actually happened with sleep testing in Australia, I'll show you the data on tests performed. So this is data from the Australian government, from Medicare data. The purple line shows the total number of tests performed per month. And normally in Australia, that's an average of around 14,000 tests. We had a little dip over January, which is usual, that's our holiday period. And by March, we were back at around 14,000 total tests. But you can see then in April, it dropped to 50% of previous activity with only 7,000 tests being performed. The red line is home-based testing or level 2 testing, and the blue line is laboratory-based testing, reflecting that in Australia, there's more home-based diagnostic testing done, with most of the laboratory tests being implementation or commencement of CPAP or review of CPAP studies. That data from Medicare is only available to April. So to give you an insight into what's happened across as we've sort of come out and have low community transmission, this is data from my own personal practice. Normally I run at around 60 to 70 total studies per month. That's the purple line. So you can see in March I did 70 studies, which was comprised of about 50% home studies, about 35 home studies and about 35 laboratory-based studies. But then with the cessation of testing at the end of March, I did almost no studies in April. And you can see the orange line picking up there. So that's when I started to introduce peripheral arterial tonometry-based testing, which I'll talk more about, as a way of trying to get sleep testing done safely during the 50% capacity, mainly by doing peripheral arterial tonometry testing and a handful of laboratory and home-based tests, which were really just ones that were commencing at the end of May. And up to date in June, it's projecting that I'll be almost back to my usual capacity at 60 studies per month by the end of June. But the difference being on the other side of our peak pandemic, a significant number of my studies will be peripheral arterial tonometry rather than level 2 studies, with that being the main difference. I've substituted a number of my traditional level 2 studies with peripheral arterial tonometry, and I'll talk about why. Unfortunately, there's no perfect test for us during the pandemic. What we really want is a test that's accurate, been well validated against polysomnography. It's simple, that patients can do themselves. It's reliable with a low failure rate. There's minimal infection risk, and very importantly, it's a cost-effective test, because particularly in India, it's a very cost-sensitive market, and we need to recognise that. You all know about level 1 polysomnography, the perceived gold standard for the diagnosis of a range of sleep disorders, including sleep apnea. It's complex though. You need expert staff, you need lots of scoring. It's not practical to be not done face-to-face. People need to come into a hospital environment. It's got to be done face-to-face. So during a pandemic, there's lots of PPE requirements. And we found in Australia, patients were unwilling to come into the hospital because, if you know, the highest incidence or prevalence of coronavirus is actually in healthcare settings. Level 2 is home-based sleep testing, which can be attended or unattended, which is still complex because level 2 studies do incorporate measurement of sleep with EEG signals as well as EMG signals. It is hard to get good quality signals at home, and that's even with setting someone up with technicians and technicians potentially attending during the night. And the data needs to be expertly scored, has a failure rate of 2.2 to 5% when set up by expert technicians. We don't really know when it's set up, given a YouTube video and told to set themselves up, which is what ended up happening in Australia once people got organised in April to do home-based testing. But we know from some of the external scorers who've looked at these studies that were performed in Australia during that time and still at the moment using that system of patients setting themselves up via video with this, data quality is pretty poor. And it's actually a lot worse than what it had been when technicians were setting people up for this type of testing. And there's still a significant infection risk. There's lots of equipment here that needs to be cleaned, to be reused. Those cloth bands, how do you actually disinfect those from coronavirus? You can simplify things a little further with a cardiorespiratory test. There's a level 3 test, but there's still quite a number of leads, often around 7 leads or so. So in this example, there's 2 respiratory leads, a nasal airflow, a thermocouple, pulse oximetry, ECG. So there's still equipment that needs to be cleaned. So you've got to consider the infection control implications of that. And the failure rate's a bit less for the more complex level 2 studies, but it's still significant. And that's the interest in other technologies such as peripheral arterial tonometry. It's not a new technology. It's actually been around 20 years. The WatchPat device and more recently the WatchPat 1 devices from Itamar, an Israeli-based company. They've been around for around 20 years and have shown that arterial tonometry, so a signal looking at blood flow in the vascular bed of the finger, is a sensitive way of looking at sympathetic nervous system discharge. And if you pair that with changes in heart rate and changes in oxygen saturation, you can quite accurately measure respiratory events. So in this epoch from a peripheral arterial tonometry study, you can see a reduction in the amplitude of the arterial tonometry signal. So that's the raw signal and that's the amplitude being reduced. So that's a vasoconstrictive response indicating sympathetic nervous system activity. This is an increase in the heart rate with the respiratory event. You've got oxygen saturation. The nadir is a bit delayed because you're sensing that a bit after the vascular response. And this is respiratory effort. There's a little device that sits just under the, or sort of above the clavicle to measure respiratory effort. And you can see reduced effort when trying to breathe against an occluded airway, and then a sudden increase in effort associated with the tachycardia and the vasoconstrictive response. That's typical of an obstructive event. So whilst Itamar have been using that technology for around 20 years, Ectosense is a company that's now got a night owl device, which is in this lower right-hand corner, which is a device that's really only been on the market for a year or two and is trying to simplify the device that Itamar had previously had, or the technology Itamar had previously used. Because the WatchPat or Itamar devices have been around for about 20 years, they're very well validated. There's been over 100 scientific papers looking at these devices in comparison to polysomnography and meta-analysis showing that they're accurate and perform well. It's a very simple test. The WatchPat 1 device, which has been heavily used in the United States during this pandemic, it's got a failure rate of less than 1%. It's a disposable device, so it's very low infection risk and meets a lot of infection control guidelines. It's well validated. The chart in the bottom right corner, the Bland-Altman plot against PSG, had a standard deviation of 10 events per hour, so quite a narrow standard deviation and good agreement between the two tests. The downside is cost. The wholesale cost of this device, at least in Australia and the US, is €100. The Ectosense Night Owl device, as I said, is a newer device. It's much less well validated as it being a newer device. There's a single study of 101 patients showing that it agreed reasonably well with polysomnography. Not nearly as well as the WatchPat device. Again, look at the Bland-Altman plot on the bottom right. The standard deviation was 20 from the mean, 20 events per hour, compared to 10 events per hour for the WatchPat, which is quite a significant difference in accuracy. But I think if you use this in a high pretest probability population to rule in sleep apnea, so you're looking at a high pretest of severe sleep apnea, I think then it's going to perform reasonably. The problem's going to be if you're trying to test too many mild patients and you've got a wide standard deviation, you may miscategorise patients. The positives are that it's very simple. We don't really know the failure rate in the real world. That study was an attended study of 100 patients, so they really couldn't address the failure rate because if there was a problem, they went in to fix it. Infection risk is really low. These devices can be a disposable sort of workflow. that uploads data remotely via a smartphone app, and the cost is yet unknown, but it's likely to be significantly lower than $100 US. So just to summarise, business as usual in diagnostic testing isn't an option during the pandemic. And we've learnt in Australia it's not an option either in our sort of post-peak of the pandemic. We've changed what we do, which you can see in my own personal data using more peripheral arterial tonometry than I had been previously. Although there are challenges with infection control in providing a service for patients during the pandemic, we still do need to provide a service. So for your own situation, consider what options are available, what's practical in your local area for your service. Thank you.